It's a 69 years old female presented with unstable angina, and for which angiogram was done, which showed a single vessel disease involving the mid LAD, and associated comorbidities is diabetes and systemic hypertension.
Okay.
Routine echocardiogram showed normal LV function and a baseline creatinine being 0.9 milligrams per deciliter, and the syntax score is 10. So this is the angiogram with the apicaudal view and as well as the pericardial view, which shows the mid LAD calcified, diseased. Uh, RCA is dominant with a very mild plaquing noted in the proximal RCA. And here we had to go ahead with the PDCA to the LAD.
You can see in the first view today that you can see there is a LAD lesion which is extending from the diagonal origin to the mid LAD, which is about 80%. Patient came with angina. The distal LAD looks like about 275 millimeters in size. There is a diagonal origin disease, and we hope to wire the diagonal and protect the diagonal during the procedure. The plan is to first pre-dilate the LAD, which seems to be calcific. Can you play the run again, please? So you can see that before the dye gets injected, there is a calcification both in the PA cranial and the LAO caudal. Can you play back the LAO caudal view? And you can see again here, you can see right from the proximal LAD, there is calcification which extends through the diagonal and septal to the mid LAD. So as we were waiting for the case, we just got in and sort of trying to wire the diagonal. I think we are in the diagonal. Small check, please. So what we'll do next is to wire into the LAD to show the IVUS. And as you can see that lesion is pretty tight. So we expect the IVUS not to cross very easily. So what we'll do is after we pre-dilate with the 2.5 non-compliant balloon, possibly we'll get the IVUS through. So there are two wires. We have the cyan blue in the diagonal, and we're now going to get a wire into the LAD. This is a BMW wire.
So this is the 014 wire which is crossing into the LAD. We had some little resistance probably because of the tight stenosis. So
Okay, so we've got two wires in, and we first will dilate the LAD and then possibly do an IVUS for you. So 2.5 non-compliant. What size balloon is this? The 2.515 balloon. So this is a non-compliant balloon. So you can see the calcification here very, very clearly in the artery, and we expect on the IVUS to see the severity of the calcium to decide what sort of debulking strategy we're going to do. Small check. Okay, let's
so
go
the
up there, please.
balloon is crossed, and we are just trying to pre-dilate with the 2.515 non-compliant balloon. I hope
Deflate, please.
they all can appreciate the calcium
So the
which was.
lesion has come up at about 12 atmospheres. Small check, please.
I think they're doing.
So before the IVUS, as my technician said, Freddie said we should give some NTG so that the vessel is not undersized in the whole bargain of doing the stenting. So here you can see that the vessel is coming up nicely. Uh, we'll take a shot now. So the vessel looks much bigger now.
So
It seems
as
to be a 3+ vessel now. So as much as possible, unless it's a very big vessel, we do a provisional strategy in our hospital. We use only two stent strategies in case we have a large diagonal circumflex with a osteal disease which is extending into the origin beyond 10 millimeters. In this patient, I expect that that diagonal is about 2 millimeter vessel. So we would not possibly go ahead and do too many things unless we pinch it during the procedure. So that's the high definition IVUS of Boston coming through. And so can we now show the IVUS pictures, please?
So now you can notice some sort of calcified vessel along with uh, from fibrotic stenosis. This is the diagonal, the lower diagonal. Some sort of calcium between 1 to 2 o'clock.
That's okay.
Oh,
So
here's the
that's the left main,
left
and
main.
here we are out of the left main and
All
the
right.
ostium. So we're making some measurements here. I hope you can see that there.
So this is beyond the septal portion we have crossed because this is a normal segment. So the area which is around 8, the reference range is around 3 millimeter.
So
So
the
coming
luminal area is about 3, maybe 3 to 5 would be the EL to EL. You can't see the EL very clearly. And then we come into the lesion now.
coming up at the lesion junction.
So obviously we've pre-dilated this lesion, and you can see from say 9 o'clock to 3 o'clock, a lot of plaque there. Here it seems to be mildly calcified only.
At the proximal LAD also, about 180 degrees of calcium is noted, which is about 32 millimeter
Okay, so this is just from the beyond the
beyond
septal to the uh,
proximal to the
first
diagonal.
proximal part of the LAD, which has disease proximal to the diagonal. So it's about 32 millimeter. I think it's a bit bigger than 3 here. And can we measure that area there? Yeah, it's about 3.5.
3.5. So
So I
probably
think
we
if,
go with the 3 millimeter stent size, about 32 millimeter, and post dilate with 3.5.
okay,
The only question arises with a 180 degree of calcium, should we use any uh,
yeah. So I will tend to use a cutting balloon
balloon?
here.
All right.
So we will use a 3O Wolverine. Can we open that to nicely prepare the lesion? Then do an IVUS once again to see how much fracture we've got of the calcium, and then possibly then decide about the stenting strategy. So keep the IVUS ready after this, please.
Yes, sir.
Small check, please. Go up, please.
All right.
So this is a 3O, 3O10 Wolverine. Yeah, it's come up reasonably well. Deflate, please. Go up again, please. Okay, so we're going to go up a little higher pressure there. Yes, please. 6, 8, 10. Okay,
All right. So let me go live,
so all right, take care.
and this is another septal which is arising at the 6 o'clock position. Over here, if you can notice the diagonal as well as the wire which is marked over here, and this is the LAD which was a little calcified, and you can notice some uh, dissection plane at the calcium beyond. And over here is all about the fibrofatty plaque which was noted. And over here the calcium starts. As we come beyond at the delivery junction, you can notice over here some cuts of the calcium.
That's a very good cut, Ashish. Yeah.
Yeah. So over here you can notice the cuts noted at between 4 o'clock to 5 o'clock position.
And I think we have really debulked this lesion pretty good. And so we are ready now to stent the vessel. And I think we're going to use a 3032 millimeter stent. So can I get a 3032 onyx stent, please? So 332
It's
synergy maybe.
synergy.
So this the aim of you would think that just by ballooning that you would get good lumens, but really what you get when you have calcium by doing debulking procedures, whether it be cutting balloons, Wolverine, angiosculpts, or IVL, is good lumens. In this patient, we have 180 degrees calcium, reason enough to debulk so that the stent expands well. Second issue is that we have a long lesion, and these are known to restenose. So we need to have, and it's in the LAD, so we need to have a good outcome here. The good part is we can still see that the diagonal is patent, the LAD is good, the lumen is good, and it's time that the bed is prepared for the stenting. Can we have a picture by that time? Yeah. So you can see that the vessel is much bigger now. So can we get the 332 balloon stent, please? Yeah. Okay, so here we go with the 332 synergy stent. The length of the lesion as uh, measured on the IVUS was 32, and we will go in with a 332. Keep a 3O balloon ready for high pressure, non-compliant ready. Small check. So that looks, it may take a cine.
I think
Yeah, I
this is
think we
a
have
good,
covered the proximal lesion.
slightly in. Yes, I think this should do. We'll take a
Small
cine
check.
over here.
Okay, let's take a cine. Okay, that looks good. Let's go up, please. What is, no, keep the 3O balloon
Slightly
prep,
in. So
please.
yes.
So you can see that the stent has uniformly come up after the debulking with no issues. Yeah, deflate and go up once more. So with these long lesions, it's better to do a couple of dilatations of the stent so that we can get a good result. Deflate, please. Get that stent balloon out.
So distal LED averages are about 3.1. If you notice 3.15 and 3.2.
So
So
we'll just have a look what we did with the,
either we can take a 3 or 3.25, go a little high pressure distally.
aspirate. Air. Okay, so you can see that the stent is nice and uniformly expanded. So there was a suggestion to take a 325 balloon. Okay, I think that may be good. We can do both 325 and go very high pressure in the proximal part and then check what you have to do and then use a 3.5 if required.
I think a nominal pressure with the 3 to 5 at the distal.
So Rahul is asking me a question whether we should remove the wire in the proximal, in the diagonal when you're doing the proximal. You know, I don't think anything will happen, even though it's a hydrophilic wire, because yeah, we'll just take a stent boost here. Ready?
All right, so we can fluoro and then take a decision. All right, we got the this. We need to go a little more.
Little bit in, yeah. Can we go off the freeze film?
Fluoro. All right, we can go
Just going to
distally.
go in a bit. Go up there. Yeah, it's okay. I'm okay. I'm pulling it back. Yeah, go ahead. So we are using the stent boost live 12, 13, 14. Deflate.
We can go a little more distally.
Yeah, I'll just do another stent boost and see. Yeah, we need
We
to
are
go in
much.
a bit, I think. Yeah.
Yes.
Okay, we still have some distance to go. Let's go ahead anyway. Here.
I think where the wire mark tip
4, 5,
starts.
6, 7, 8, 9, 10, 11, 12, 13, 14. Deflate. So we've gone up to moderate pressures here, and here we'll go at high pressure. Go to 20. This is a 3 to 5 balloon. Deflate. Go up here. 20.
So these all are being done with the high pressure. with a
Deflate.
3 to 512 non-compliant balloon.
Okay, now we'll quickly do an IVUS and have a look after a small angiogram
So
just
we
to be
shall
sure
give
we have
some
not
nitroglycerine and
created
then
any
take a shot.
dissection or anything of that sort. Some nitroglycerine, please. Okay, ready for a shot? Okay,
So
looks
even
pretty good.
after the high pressure of 3 to 5 at the proximal juncture, it's yet the diagonal is still flowing. There's not much of any ECG
IVUS, please.
changes. So let us go with the imaging and then decide whether do we require any more high pressure dilatation at the
Okay, let's wait
proximal
5 minutes
juncture.
more.
So this is the IVUS, which is again crossing
We're
very
distal to the stent.
smoothly.
Take some
So we are at the
pictures now.
distal segment of the IVUS and the pullback has been started. Coming to the distal segment, which is no, this is the stent portion where you can notice that not much of dissection was noted. The expansion is reasonably good. And this is all the calcified portion where the stent has expanded well. And coming to the proximal segment of the LAD, over here, you can notice,
The left main.
okay, this is the left main, and which is normal. So coming to the measurements,
Let's take some measurements now quickly, and then we'll decide whether to do anything for the proximal part. So we got a good distal area of 7.7.
7.7,
Can we have the
probably,
minimal lesion diameter, minimal stented diameter, sorry?
yeah,
Yeah, maybe that's the place where we have the minimum stent. That was where it was very calcified.
it is all about
7.3,
7.3, 7.5,
7.4,
probably
7.5. And
the
the
proximal
proximal.
segment alone just a 3.5 balloon with a nominal
Yeah.
pressure.
So we'll just do a 3.5 for the proximal because we feel it can be done a bit better. And then we are done with the whole thing. 3.5 balloon, please, shot.
Short one.
Short balloon,
Hmm.
please. 8 or 10. Okay. So I think this case is a demonstration of how we do debulking and IVUS guided imaging for a long lesion and how you can optimize your result by using debulking and sequential IVUS imaging so as to get the maximum lumens. Go up to 20. So this is just to optimize the proximal. We're going to 20, 3.5. Yeah, so that's good.
அவங்க லைவ் எடுத்துட்டாங்க
That's what we will finish with, and we pull that out.
மீன்ஸ் ஒர்க் பண்ண ஆரம்பிச்சிட்டாங்க.
The wire slightly.
Yeah, you can pull the wire out. Just take a shot now.
கீழே உள்ள நல்லா இருக்கு இந்த
There
ஜங்ஷன்ல
we go.
மட்டும்.
So you can see that the result is looking very good. In fact, the proximal LED stent is bigger than the native LED ostium. The diagonal is still preserved, and that is the great part about using debulking devices. Take a perpendicular view. All the side branches are preserved, and that's the other good part of the synergy stent, that you can literally preserve every branch as you go in. So I'm pretty happy with this result. And Ashish, are you okay with the whole thing?
Yes, sir. So the stent expansion is good. Diagonal is flowing. There's not much of CEC changes. No patient is having any discomfort. So
Thank you very much. And I thank all my sisters and techs at MMM and Ashish and Rahul for the case.
thank you.